Thank you. I, um, yeah, I'm honored to be here. I'm always a little speechless when I'm with this group. When I first got to Asper a little over 2 years ago, in my office was a box, the original box set of the crisis standards of care work that the academies did, some years ago. And, as I was trying to come up to speed on what this job entailed and what Asper's mission really included, that was one of the fascinating things to read and to sort of understand the scope of what we were doing and some of the things that were facing us that I wasn't as familiar with. But I'll be honest, it was a little academic in some ways because we were in a little bit more of a quiescent state at that time. But then, moving forward a few months into that, and then we were hit with COVID. And one of the things we did very early on, this is February of 2020, when we were starting to get an idea of what this could possibly entail, we approached the academies and we formed a standing committee. It's called the Standing Committee for Emerging Infectious Diseases and 21st Century Threats. And that was just meant to kind of deal with the COVID issue and any other things that would come up around that. And then as things started progressing and we got deeper into the year and the whole magnitude of COVID really made itself apparent, we had formed a healthcare resilience working group. And many of you know Jack Herman and Paul Reed and some others that were key parts of that, John Redd. As that started getting going, we realized that the crisis standards of care really needed to be looked at again. So we approached the academies again and we reinitiated some work with that. So we appreciate both the academies and then many of you for all you've done this whole time to help us out with this. Now I'm here today representing Dawn O'Connell. She's the new Assistant Secretary for Preparedness and Response. She wanted to be here to mainly, more than anything, to express her appreciation for something that's this important and for all that you're doing for this. She's constantly torn because of the many different competing issues that are going on right now. So I guess the message I will give you from myself is don't see this as any lack of priority on her point. I know what she's up against and what she's dealing with day to day. So as there's follow-on work, maybe there's an opportunity that she can address the group. But she did very much want you to know that she sees this as vitally important. Amidst all the work and the rhetoric and the policy making and work that's going on for, the different medical innovations, the medical countermeasures, the vaccines, the therapeutics, the diagnostics, all the science-based work that's going on, it's very important that we make sure that the other parts of the equation are still being addressed. And so, on her behalf and also from myself and everyone else in Asper who's been involved, we really appreciate all the work that you've been continuing to do here. And again, express how important it is. I think, Rick will talk a little bit more specifically. He's the clinician here representing Asper, so he can talk more about some of the real issues that, on the ground that he's seeing it and as it pertains to the Asper mission. But, I've from the beginning been very concerned about the impact that this has had on all the clinicians, doctors, nurses, EMTs, social workers. I mean, there's a continuum that we've been trying to address and making sure we're understanding the needs there. The policy matters and these other issues are one thing, but really what it all boils down to is what are we doing to help those clinicians to ultimately be of the highest benefit to the patients. So I think I'll stop there and turn it over to Rick. I'll try to stay on the call as much as I can today. And I'll certainly try to get back on at the end on the reflections portion. And if there's anything I can personally take back to Dawn, I'll do that, or with the rest of the leadership staff then Asper and HHS. So again, can't thank you enough. And I look forward to the rest of the discussion and the other output that we'll get from this group because it is so important. Thank you. Rick.
Thanks, Eric, and thanks, Chris, for those remarks. I want to thank the National Academies for years of work on crisis standards of care. I mean, the volumes in Chris's office speak to that, speak volumes. I'd like to share some observations based on listening to many clinicians during the pandemic. We've really had little experience with implementing crisis standards of care. We now have vast experience. Crisis standards of care, or crisis care, is now a discussion among many far beyond what used to be limited to the National Academy's discussions. I'd really encourage us all to listen to those conversations outside this room or Zoom platform really carefully, especially those among the public and those among clinicians. I know you have already, I realize that, but I believe it's essential to continue to do so. It's a two-way street. Thought leaders can learn from those with experience with crisis care decision-making at the bedside, just as those clinicians can learn from the years of work that you've done here. The conversations among ethicists, attorneys, hospital leaders, public health officials, and all those jurisdictional authorities are really important and have been really foundational in getting us any crisis standards of care at all. We've seen how crisis care was implemented with or without standards across the nation. Some of those locations and some of those clinicians had well thought out proactive approaches, and some with little or no planning at all. I think at its very core, crisis care happens between patients and their doctors, nurses, and other healthcare professionals. And listening to those clinicians out there, some had little or no awareness of crisis standards of care prior to making life or death decisions the best they possibly could with the best of intentions. This pandemic started in early 2020, and actually the virus is called COVID-19. It's now November 2021. The phrases that increasingly dominate discussions among clinicians include moral injury, compassion fatigue, and attacks on clinicians. And those phrases go actually far beyond how a clinician feels. Clinicians are throwing down their stethoscopes and walking away from medicine. When I say clinicians, I encompass the various disciplines: physicians, nurses, other professionals in hospitals. Chris mentioned social workers, respiratory therapists, and on and on. And also EMS clinicians. Notably, when I talk about people throwing down their stethoscopes, an NPR story in July noted that in Montana, some EMS calls, when someone calls 911 for emergency medical assistance, nobody responds. So we're not even talking about, right? I mean, there's no response. I think, at its core, crisis standards of care addresses the times when we have scarce resources, especially given the healthcare workforce shortage, which is here and now. It will also likely last for years. We now have and will continue to have a healthcare delivery system in the United States that is diminished in its capability and capacity. Scarce resources. And how does this group address this challenge, a profound challenge that our nation faces, or is that for another group to address? Got a few other questions as well. How do we support clinicians in doing the best possible when they have to implement crisis care with or without declarations or standards? If curriculum committees and continuing education requirements can't find room for crisis standards of care, how do we actually support clinicians in the moment when they must make those decisions? How do we best support clinicians after they've been forced to make decisions that result in profound mental anguish, sometimes with grave consequences? So much really important work and good work has been done already by yourselves and the academies. Even with a pandemic and the profound fatigue that we all have and feel, I think it's really hard for anyone to move on to new ideas. And I believe really strongly that acknowledging the fatigue and understanding how that impacts your work on crisis care and developing a strategy to tackle that head on, the fatigue itself, is important. Based on our experience with the pandemic, I don't think iterative change is sufficient. I really encourage you, the experts, to be bold in your thinking and approach. Anything new threatens the old. Yet I would really encourage you to be open-minded. It may be a once-in-a-century opportunity to get this better. I frequently reflect on how fortunate we developed crisis standards of care before the pandemic. I'm grateful that people like Dan Hamfling, John Hick, Eric Toner, and those of you participating today, and to the National Academies who have pioneered this work and continues to move it forward. With that, thanks very much. Back to you, Eric.
Thanks, Rick, and thank you, Chris. Your comments are much appreciated. Before I ask a couple of questions, I want to remind the audience that you have the opportunity to put questions into the discussion as well. You can do this by making comments or questions via the box that's below the live feed. And then we have staff who will be reviewing these, and we will try and get your questions into discussion as best we can. So, Rick, I think the questions you asked are all the right questions and the same ones that we're wrestling with. Excuse me. I wonder how you see the federal government's role in crisis standards of care.
Well, I can start with that as maybe for as I guess what you'd say as a non-expert here, but and as a non-clinician. However, just like if you look at the whole even the title for our organization, for preparedness and response, the more we can do to provide all the tools in advance for the clinicians and as well as the policymakers at the state and local level. That's much what we're doing. And I guess I also want to be clear that, like I said earlier, we focus a lot on the technical aspects and the scientific and almost like the hardware aspects of what we would need to do to approach a lot of these problems. As this whole pandemic has shown, there's so many other aspects of communication with just understanding what the barriers and the challenges are, and then addressing those, sometimes with technical measures if they're possible, but we've got to make sure we're dealing with the non-technical aspects as much as possible too, and making sure that those have attention both within the department, within the administration leadership, and as well as on the Hill, just so they all understand what the impacts and the concerns are. So I think the federal government has a role, but it can't be the federal government alone. We've got to make sure we do that in partnership. And we've been fortunate, like Rick said, that this group, and then with our state, local, territorial, and tribal partners working with us and trying to be as much as possible one team. I don't know, Rick, if you got any other comments?
Yeah, Chris, no, ditto and exclamation point to what you said, but I guess in addition to that, in being involved in some way with the development of crisis standards or making an effort to teach it and so forth, so on. My observation is that denial is such a powerful tool. I mean, it's just extraordinary. And this is, at least in my experience, potentially one of the crisis standards of care. Nobody wants to do this. I mean, at the bedside, the public does, everybody wants it like not to have to do this. And yet, when you work in the federal and then try to work with locals, states, territorials, and you try to work with clinicians on this, it's out of sight, out of mind. Nobody wants to do it. And I think that Chris is absolutely right on providing them tools and finding areas where the people, when I say the people, I'm not certainly the public as well, but I think that engagement with state and locals before there was much more reluctance to work on this. Hopefully there's a whole lot more receptivity today than there was before the pandemic. But I guess I'm just doubling down on, don't underestimate how difficult this is. And I think everybody that's worked on it realizes that. And the federal government alone is not the magic bullet solution to all this. That's for sure. The grassroots piece, the clinicians embracing, even knowing the ethical concepts would be a huge leap forward, and providing those kinds of tools, I think, is really critical.
Well, I agree with those comments and appreciate them. This is a question that I get asked often, which is, well, why doesn't the federal government just tell us what to do? And I try to explain the realities of our federal government system. And but the government has been doing a lot. Rick, you've been running the Project Echo calls. We've had webinars from Tracy. CDC has done COCA calls. We have issued reports through the national academies and put out calls to action, et cetera, et cetera. And yet it is frustrating, as you pointed out, Rick, that there are a number of clinicians who've never heard of crisis standards of care. And so I wonder if you have any thoughts on what more can be done, whether it's by the federal government or by the national academies or anybody else. How do we get the attention of everybody who needs to pay attention to this? I would have thought the pandemic would do it, but so far it doesn't seem to have.
Let me, if there was one thing I would do, I would put it in, I would really use whatever levers are available to make this into clinicians' education and training. Because as I mentioned, it's the patients and the clinicians at the bedside. That's where this happens. And you had to have a construct to begin with. And now I think it's just critical to bake it in. And how is it that the national academies, how is it that the federal government can be supportive? That's one. I'm not making a policy. I don't make policy decisions, but at least my observation in talking with clinicians, listening to them, the extraordinary variability in their awareness of this at all. And some of the questions I've asked clinicians makes it apparent that they just did the best they could, and even crisis standards wasn't even in there. Those two words weren't even connected. So now I think is the time to really focus on that. Chris, please, I don't want to. Yeah, please.
Well, we're probably running out of time, but that's a great question, and I'd like to pose it back to you and to the group. The worst thing we can do here is to sit in a small government-only call or a meeting where we discuss what we think we need to be doing. We've been trying to reach out to stakeholders, and you can define stakeholders as broadly as you could imagine. But really, I turn the question back around. What do y'all think we should do? And if we don't have time here, then I'm happy to entertain that offline.
I don't think I can speak for our group, but I think there are ideas, and I think that'll be part of the work going forward is to not only revise the guidance, but think about ways to promulgate the guidance and foster its adoption. But we are out of time for this session. I thank you both for your comments. It's very much appreciated. And we'll move on to the next session. So thank you both.